National Hospital in Pain Management Department as a consultant. I'm going to introduce a few blocks collectively called shoulder blocks, suprascapular and axillary nerve blocks, as well as subacromial percentage. They can be given as single injections or they can be combined, two of them or all three of them, depending on the condition of the patient, indications and requirements. Now I have put down some of the indications of these shoulder blocks as rotator cuff pathology and adhesive capsulitis, shoulder impingement, subacromial bursitis, and as you all know, this interscalene block is the gold standard for the shoulder anesthesia and anesthesia, but in certain circumstances, when the interscalene block is contraindicated in patient severe COPD or severe lung pathologies, when we do not want to block phrenic nerve and compromise the diaphragmatic movement even by 20 to 25%, then you can use these blocks that can produce not the same but the similar block, and you can always use the adjunctive or some supplemental blocks, supplemental methods to control the residual pain. I will not go into the contraindications. You all know the contraindications. These are the same as for any blocks. Now briefly, the neuroanatomy. The shoulder is innervated by 5 nerves: the suprascapular, axillary, lateral pectoral, musculocutaneous, and the subscapular nerves. But the major contribution is from the suprascapular and the axillary nerve. As you see from here, that suprascapular, it emerges from the superior trunk of the brachial plexus, while axillary nerve is the terminal branch of the posterior cord. There is the course of these two nerves. The suprascapular nerve emerging from the superior trunk, it traverses the suprascapular notch, which is at the superior border of the scapula. Then it goes to the supraspinatus fossa, supplying the supraspinatus muscle, and winds around the greater scapular notch or spinoglenoid notch, and it goes to the infraspinous fossa, where it supplies the infraspinatus muscle and also gives some twitch to this muscle, the minor iris minor muscle. Now, there is the supply of these nerves, suprascapular and axillary, supplying the different muscles. Suprascapular supplies the supraspinatus, infraspinatus, and iris minor, and axillary supplies the deltoid and iris minor. Then suprascapular also supplies the shoulder joint bones, and same axillary supplies the humeral head and proximal humeral head, proximal neck, proximal part of the humerus. It also supplies the synovium, and axillary supplies the overlying skin of the diaphragm. Now, we will be practicing the technique of these blocks and we go to the for the practice session. But here, just to give an idea, you can see that in this picture the patient is seated with the probe in the scapular plane. On the the idea is just to scan the suprascapular fossa. We can identify the structures, the trapezius, suprascapular and supraspinatus muscles, and the spine of the scapula with the groove and the nerves in the artery. So we will be practicing these things in the session, the practice session, and we'll be discussing in detail here. Now this is the axillary block. This is not the axillary brachial plexus block, but it is the axillary nerve block, as it is it emerges from the brachial plexus, and then it curves back, and it goes to the posterior part of the humerus. And so when you place the probe on the posterior to the humerus, then you can appreciate the head of the humerus, and you just move distally, and you can see these structures. In this, you can see the teres minor muscle, the deltoid muscle, and this is the thumb sign, which is formed by the teres minor muscle, and the fascia of these two muscles, it shape the nerve. This is the fascia of the teres minor muscle, fascia of the deltoid, and this is the fascia of the teres minor muscle, and these two fascia, they can shape these two structures here, and the idea is to place the depository drug within this space. Now briefly the subacromial bursal injection. As you know that the bursa is a fluid-filled sac. It is presented in two structures, normally the bone and the soft tissue. This is the largest bursa in the body. It communicates with the subdeltoid bursa, and this subacromial bursa, it is sitting on the supraspinatus muscle tendon and underneath the deltoid muscle. And here is the technique, and you place the probe on the lateral edge of the acromial, and you can see the structures. See, this is the acromial, and this is the greater tuberosity of the humerus, and we can see the supraspinatus muscle, and it passes from under the acromial, and here we can see the bursa. It is the bursa. The two white lines filled by a small amount of fluid. When it is inflamed, the fluid is released, and here we can give the injection to this bursa. And this is usually given in case of if the impingement, shoulder impingement is due to bursitis. Again, the complications, same as been discussing, and the superior part of the chest, we should be very careful about the pneumothorax. Thank you.